Thank you so much, everyone. I know there's still some people kind of coming in, but we're going to kick off now. Just want to say a big happy Sexual Health Week. It's very lovely to have all of you here, and I'm really thrilled to be joined by such a wonderful panel of experts in our field, and we get to chat about stuff that I feel very passionately about, and I know all of you do as well. Just a heads up that we are recording this, but we're recording our faces. So I hope that that's okay with all of you as participants. And yeah, we've got a question box, a Q&A box at the bottom of the Zoom. So while we are all chatting, please send your questions in. Obviously, please make sure that they are respectful to the panel, and on topic, I guess, but it would be really nice to get a good chunk at the end of this hour that we have together to hear from all of you and to bring up some different discussion points. I am Ruby Rare. Hello. I am a real Brook cheerleader, as someone who worked for Brook for a long time and is very proud to be an ambassador for the organisation now. And it's a real joy to be chatting all things chronically online this Sexual Health Week. The good, the bad, the ugly. Online spaces are essential in terms of delivering sexual health services, and there is so much innovation, but there's also challenges that we have to meet and kind of pivot and be creative with how we work around them. So today we're going to be looking at the online world and how it's shaping our attitudes and behaviours when it comes to sex and relationships, but also the services that we are all a part of and we all kind of want to innovate in really exciting ways. To give you just like a little bit of a background before we jump into a wider discussion. So digital access to sexual health services is changing a lot, especially in the last couple of years. I've really noticed a shift in the conversations that we're having, and I imagine that lots of you feel the same, especially in terms of STI testing, but also PrEP and access to DoxyPEP in the future, and all forms of contraception. All of this is so much more accessible when we're using digital services. I've got a Brook stat here of like 41% of sexual health consultations took place online last year, which is really impressive. And 10 years ago, like that was a completely different landscape. So things have changed in quite a short space of time and a real positive. However, at the same time, there are some challenges that we are facing. One of the ones that I really want to draw into the conversation today, we'll be talking about it a bit later, is a drop in the uptake of contraceptive pills as a form of contraception. Where's my data for this? This is from the NHS, but it showed that there has been a drop-off in women using the pill or a contraceptive pill as their primary form of contraception from 47% to 27%, and that's over the last 10 years. So there are lots of complex reasons why this has happened, and I don't think we necessarily need to look at it as a negative. However, there is misinformation, especially on social media, but also in other online spaces, that has complicated this as a conversation. And I think the way that healthcare meets those complications is really interesting and nuanced and important. I need to just say the word AI to like get it out of the way. I don't know how much we're going to be talking about it today, and I can sort of feel all of the other panelists like groaning as I say that a little bit. But there is obviously this huge growing concern. It's like the elephant in every room of how AI is going to impact our digital services, with more people turning to services like ChatGPT for health advice. And I don't know, more than anything, that is something that makes me want to be a bit of a Luddite and like stick my head in the sand and just go like, I don't want to look at this. So maybe by the end of this conversation, I will feel a bit soothed by our wonderful panel. I would love to introduce you to, we've got Chris, Sarah, Anatole, and Sam. I think the best thing is for all of you guys to introduce yourselves. If you can just say a little bit about the work that you do, and I think let's just keep it at that for now. Chris, do you want to kick things off?
Thanks, Ruby. It's great to be here. My name is Chris Howroyd. I'm the Chief Exec of SH24. We're a specialist digital health service working in partnership with the NHS and other clinical providers like Brook, sensibly to improve access to sexual health services through offering STI testing, conception, treatment online. Ultimate aim being to improve public health outcomes. I'm a product designer by background. It's quite unusual to be a CEO as well from a design background. So as you can imagine, I'm really passionate about user experience, so champion our experience through the service across all touch points, adoption, adherence, whether they be in digital, physical.
Great. Thank you so much, Chris. Sarah?
Hi, everyone. My name's Sarah Fuhrmann. I also work at SH24. I'm one of the business development managers. My background, however, is in frontline therapy. So I'm a trained health psychologist. I specialize in infectious diseases. So to be working in the digital space, coming from a frontline clinical provision space, is quite a shift and is really testament, I guess, to my belief in the importance of how both terrestrial face-to-face services and digital services can and need to work together to safeguard spaces for people to access face-to-face, but also to have multiple access points. So I've lived and breathed both worlds, and I think they can coexist beautifully together. So that's why I'm here today.
Oh, what a flourish as well. I love that phrasing. Thank you, Sarah. Anatole.
Good afternoon, everyone. Anatole Menon-Johansson. I'm the clinical director at Brook. I've been working for Brook since 2005. I'm also a consultant in Guy's and St. Thomas's, working in sexual reproductive health. And my side hustle is SXT, which is a contact tracing tool for anonymous partner notification. But my real passion is, how do we leverage digital tools to deliver more effective services, and hopefully in this discussion we'll illuminate some of those.
Gorgeous, thank you. And last but by no means least, Sam.
Hi everyone, I'm Sam Hepworth. I'm head of communications at Brook, and so I that look after a lot of Brook's health promotion communications. So whether that's on social media, whether that's our campaigns, promoting our clinics, promoting our clinical services. And what I'm sort of very interested in, is echoing some of the sentiments that Sarah said, really, is really thinking about how that when it comes to health promotion and working and getting those messages out about sexual health, that interplay between digital services and also community-based initiatives, and how those two things can go hand in hand. And I think that's something I'm looking forward to speaking about a bit more today as well.
Wonderful. Well, and also Sam's the one who put together this panel, so thank you so much, because I think we've got like so many different access points, which makes me really excited. So let's dive in. I want to start with you, Chris, because SH24 have been such innovators in the way that digital services and sexual health have kind of combined. And it's been a real joy to see that from afar. But I'm curious, kind of within SH24 land, like what is the general landscape at the minute in terms of online sexual health and reproductive services?
Yeah, it's certainly been an interesting journey. I think today's provision is certainly completely different to that it was 12 years ago, which is when we first saw the initial online services start. When we were running the design discovery stage in SH24, I spent a lot of time in clinics, not only in clinics, but also standing outside of clinics, so amongst the queue of people desperate to be seen. Demand clearly outstripping capacity, as it still does today. I describe the adoption of online services as being steady prior to COVID, and then during COVID, rapid and expansive. And although they still exist, it's really difficult to find a region, thankfully now within England, which doesn't offer access to sexual reproductive services across England. And for a good reason. So data suggesting that digital services really promote access. And so thinking beyond the forced acceleration caused by COVID, online services have been driven by and constrained equally by funding. And I think the initial modelling was certainly based around migrating non-complex cases online, and that concept really being delivered by freeing up capacity in clinics. And now we're beginning to see a blurring of the line between complex cases, more complex cases being delivered online hand in hand with clinics.
Do you mind just giving a distinction between complex and less complex cases for the audience? Well, actually, honestly, for me, because it's really helpful to have that distinction.
Yeah, I mean, I would suggest that complex cases require more oversight and involvement of a clinician, ostensibly.
Okay, so that's from the kind of clinical side as well as emotional safeguarding. It's kind of across the board.
Yes, absolutely. Risk, regardless of whether it's clinical or not.
Great.
Yes.
Thank you for clarifying. And then in terms of the impact that these services online have had, like on wider public health, is there anything else that we can anything that you want to highlight?
Yeah, I mean, there's no doubt that online sexual reproductive health services have had a significant positive impact on accessibility, improving access, particularly to underserved populations, and reducing barriers like stigma, time poor people, and geographical limitations. I appreciate there are many studies out there, both in progress, have been published and unpublished. But if you consider the number of STI tests across England, the trend continues to be that the vast majority online versus in clinic.
Yeah, it's kind of shocking how I was thinking before, while I was kind of prepping for this call, I've been in this sector for a decade and thinking about the beginning where like online testing just felt like this myth that maybe some people were privy to, and working in London there were like some boroughs that you could have it and it felt really exciting, to now that being like the kind of initial point of entry for most people is a real game changer. I'm kind of curious, Anatole, I want to bring you in to talk a little bit about in-person services existing alongside digital services, because don't worry, digital services are great. That is not to be disputed. But I think we're all in agreement that like continuing to have really well-funded and like adequate face-to-face services is essential alongside anything that's digital. What are like the knock-on effects that you felt from digital services being maybe prioritized in some cases, but also just like continuing to grow more and more?
Well, 48% of all tests last year, STI tests, were done online across England, which is a phenomenal statistic. And the channel shifting, which is the trendy term for moving people who can just do a test online, that has had a massive impact on clinics. So it's freed up capacity. It's allowed us then in clinics to think about, you know, how we deliver services, and it's about skilling up staff and making sure we can deal with more complex stuff. And we're not just talking about STI testing, we're talking about the provision of contraception. And it's possible to deliver even depot injections online, so you can send those to women. So, you know, there's a lot of really good work that can be done by patients themselves at home in the context of digital services. And, you know, that's to be celebrated. But, you know, in clinics, we are seeing record numbers of gonorrhea. It's the highest on record as of last year. Their syphilis is also around 10,000 infections a year. I think we're close to that. So the launch of the 4CMV vaccination is a way to try and address gonorrhea in high-risk groups. So that's a meningococcal vaccine. It's given to high-risk groups now. Doxypep has also been launched in the UK to try and help people in high-risk groups not catch syphilis. But you know, still we need to get people into clinic. We need to get their sexual networks informed about the risk in that network of a positive diagnosis and get those people into clinic. And you know, the challenge that I see going forward is that yes, we're improving access, but you know, we've only got finite resources, and you know, our diagnostic yield depends on where people test. So in London, you know, 50 people test to make a diagnosis of gonorrhea, whilst in clinic it's on average, I think 8 or 9 people come in because they're coming in with symptoms. So we don't have to test as many people to make a diagnosis, and 1 in 2 partners are positive. So there are, you know, I think we could do more with digital. We can get in touch with the higher risk patients more, and then we can offer so many other STI prevention services. And then, of course, contraception, fitting implants, fitting non-hormonal and hormonal coils can only be done in clinic at the moment. We haven't yet worked out how to do that online. So
I don't
there's
even
still
need to work that one out, honestly.
Yeah.
My whole body just clenched. I need to be doing that.
So we, there are some things that we still need to do in clinic and will do in clinic. And so, I could talk all day about this and the use of AI, but I do see a real opportunity, especially with online services, where we're collecting a lot of data, and we're looking at where we're accessing people, how we test them, where we can use machine learning and other basic forms of AI to identify who's more likely to return a test, who's more likely to test positive, how to engage people, and then also there's so many health subjects that we can touch on when we engage with people around sexual health. So, I think there's lots of great opportunities to do more even with digital than we are at the moment.
Yeah. Something that I don't know if this feels particularly nostalgic is like there's a human element to in-person services that, when it's good, can be absolutely phenomenal and can change lives and can, tackle stigma and shame and misinformation in a way that is really profound, but that requires a lot of time and care. And so what I'm hearing from you is being able to free up some of the time from your clinical teams to allow people to do that work for the people who really need it the most is a real positive.
It is true. And but I suppose I remember the journey from the beginning. I remember, seeing the great design developments that Chris was doing with SH24, in Lambeth and Southwark, where it was starting. And you realise there's a lot of resistance initially from clinics, about this idea of, patients looking after themselves and testing online. And a lot of that moving people online, some of it was, highly specialized individuals doing simple stuff, but a lot of it was healthcare assistants, within the clinic. So as we've moved patients that have simple needs online, clinics have had to think again about which staff they employ and how we train them up and how we deliver more. It just meant that clinics have to think again about who's delivering what, and skilling up healthcare assistants to deliver second and subsequent vaccines, for example. That's another great thing we can do, and you can't do that online yet.
Yeah, so constant innovation. I want to turn to Sam next to talk about digital tools. This is kind of how we first started working together. A lot of my work now exists on social media, and actually, to give all of you a little peek behind the curtain, Sam and I were talking about this just before, of kind of the real complications of talking about all of these subjects on social media. It's a fickle beast, and there is so much potential there and a lot to be positive about, but a lot that is also quite difficult. Can you chat to me, Sam, about kind of the key things you're prioritizing right now with using digital tools and how that helps with your health promotion work?
Yeah, absolutely. So I think with the work that Brook does, social media plays a huge part in the way we do our health promotion work. And I think what's really important, though, is to understand where the strengths of social media is as a health promotion tool, and also being realistic about what its limitations are so that you can use it as effectively as possible. I like to think about it as two separate things. I like to think about organic social media and paid targeted social media as being two kind of separate things, really. In terms of that organic social media, and this is something that I know I'd see your work existing in this kind of ecosystem as well, Ruby. It's really great space to be putting out general messaging about sexual health and well-being, and information there that's going to really combat stigma and educate people and really enlighten people about the subject and kind of raise their awareness about how to look after themselves, how to kind of have a happier and healthier sex life and things like that. And I think that organic social media is really great in that area. I think where the limitation for organic social media comes in is in that localized level of trying to kind of direct people into localized services. one of the issues you have with organic social is you can never guarantee who is looking at it and if they're in the right area. And because digital services, are so specific by postcode and things, can be a bit tricky. And that's where I think that paid social media really comes in as an effective tool. Creating posts that you can target to people by geography, also by gender and age as well, means you can direct people into kind of the services that they need into their locality, whether that's STI testing or condoms by post or PrEP and things like that. I think even with that, though, there are still some limitations that are important to kind of think about. I think an important thing is thinking about that social media is only one part of that digital journey. And it's really important that the website or the interface that you're directing people through to is really well made. The user journey is really smooth and the user experience is really good, because otherwise the social media post might direct them, send them through to that website. But if they find that website challenging or complicated or not clear, you're going to kind of lose them at that point. So it's really key that it works in tandem with whatever website they end up on at the other end. I think the other issue as well is about how we reach like specific targeted communities and groups through that targeted social media. Now, there's a limitation to what you can target on social media, paid social media. When I started doing this work for third sector organisations over a decade ago, it was a very different story. You could target people based on all kinds of characteristics, and it's probably a very good thing from a data protection perspective that we're no longer able to do that, but it does make our work a bit more challenging. And so I think you've got to kind of be realistic about, where you're going to connect with very specific communities, and that's where that face-to-face work comes in as being really, really vital. So if you're wanting kind of really effective community-based health promotion work, there needs to still be that work on the ground with communities, and it needs to kind of go hand in hand with that social media work as well. To give you an example of what I'm talking about, there's a project based in Bristol called Common Ambition Bristol. They do excellent work engaging the local Black, African and Caribbean community in HIV prevention messaging and things like that, doing really great community work there. And that work is primarily face-to-face, but it's also backed up with that social media presence. So it's those two things going hand in hand, really, to make sure that we're reaching those audiences. And I'm kind of interested in finding other ways for those things to kind of interplay with each other. I think there's a lot more we could be doing with something like WhatsApp to kind of be reaching those communities as well, and sharing messaging on that platform and creating content that's going to be very shareable and for people to kind of forward on to one another and things. And that's something we're beginning to kind of start experimenting here with Brook at the moment.
Can you share a bit more about that? Because I know that this is quite silly. I sometimes forget that WhatsApp is a social media app. It just is in a different category of communication in my brain. And so I know I've put you on the spot here. We don't need to talk about it too much, but I'm really curious about how.
Yeah, so it's really interesting that there's various people aren't maybe necessarily aware of some of the functionalities of WhatsApp, but there's a whole, if you go to the little updates section on your WhatsApp profile, there's a whole area with broadcast channels. And, people can follow, Liverpool Football Club, for example, or all sorts of kind of businesses and organizations have broadcast channels on there. It's a one-way form of communication and pushing sort of messaging out. And it's not been used massively by third sector organizations and charities. It's been used a lot by things like the British Red Cross and UNICEF in sort of disaster relief kind of contexts. But I think there's real scope for sexual health services to kind of be using this in that sort of community-based way. The NHS have started using it to kind of as part of their health promotion work and thinking about developing content there that's going to circulate amongst people. So people might not have Instagram, they might not have TikTok, but they're probably in a group chat somewhere on WhatsApp. And it's that thing about how do you create messaging and create content there that's people are going to want to forward on to kind of educate people about services. I'm quite interested how that could work as well to complement some of that community facing work too.
The sexual health nerd in me is really pro that. And then the like day-to-day me has that kind of panic, fight or flight idea of like another group chat, of going like, I don't think I can do it, I don't know. But I try have faith in you to figure that out in a really innovative way. Thank you so much for sharing a bit more about that. And Sarah, I want to come to you now and kind of piggyback off that, the idea of the need to have different approaches to connect with different communities. Like, what in real terms does that look like for you to create a really well-rounded sexual health service that is, you know, I think all of us have inclusion like at the core as one of the pillar stones we always want to be like thinking about. How does that work for you right now?
Yeah, thanks, Ruby. So, and Chris, please also jump in from a design perspective. I think it depends on our definition of, and this is going to sound a bit silly, but our definition of what is inclusivity. I think sometimes when we think of inclusivity, we think about, you know, group membership, but actually it's far bigger than that, right? So there's our demographic criteria, there's our group membership, but we have multi-group membership. We are intersectional people. And it's also not just about how we or who we are as people, because traditional, I guess, service delivery models have focused on targeting offers to us or have designed sexual health services around that group membership. So if I belong to X group, I get offered or given Y. But actually, it's broader than that. So in terms of creating an inclusive space online, you know, there's lots of different tools that we use. So that might be from the way we design that sort of user experience, that first point of access. So, you know, how legible or illegible is the screen that someone's using? Can they use a screen reader? So we ensure that our websites, for example, are accessible both as a you know, from a laptop basis, but also optimized for mobile or for tablet. Can people understand the images that they're seeing? Can they read the text that they're reading? So our reading age, for example, is designed to be between 9 and 11, which might sound quite young, but actually we need to factor in that we don't know who is going to be utilizing our website, and we need to make it as easy to understand as possible. Using translation tools, people can integrate translation tools and digital tools they use to navigate digital spaces. So ensuring all of that is done from a design perspective. So that's sort of one aspect, but then also redefining that sort of idea of inclusivity and group membership. So again, traditional testing models, like I said, have said, well, if I belong to X group, I'm going to get given Y. But that makes and finds us in a place where we make quite assumptive practices. So, you know, I might say that I am a man who has sex with men. And does that mean, though, that I should receive a triple site chlamydia and gonorrhea screen? Because that's assuming that I am engaging by proxy of my gender identity or my sexuality, that I'm engaging in receptive rectal sex, for an example. But that's not necessarily true. So actually shifting away from a mandated model, and something that we're very, very passionate about, is shifting from that model. And we can only do what we are commissioned to do. And that's another conversation potentially for later or another day. But making sure that we can give as much license to service users as possible, as much choice. And we've been doing some work with some really forward-thinking commissioners and changing that landscape to say, actually, people can opt into tests or opt out of them. And we're seeing a real shift in the types of tests that people are taking up. So people are actually, you know, where we may have commissioned a single site screen before, people are actually opting into dual and triple site testing. So actually people from who identify as, say, heterosexual are not opting for maybe a vaginal swab, but are actually opting for a rectal swab because maybe they're having rectal sex. But actually people who traditionally might have been offered a rectal swab are actually only opting in for an oral swab. It not only gives license, but it makes people feel more confident about their sexual health. They then don't feel targeted. We're not assuming their sexual practices based on the risk questions that they answer. But also it also helps from a social value and a waste perspective as well. We don't want people being sent a test kit that they don't want to receive, that then they're not going to return to us. So there's two things there.
Yeah. Gosh, there's so much in there. Thank you very, very much.
No problem.
Like I'm in heaven right now hearing all of
No, I was just gonna say, you know, and part of that also is, you know, thinking then in that sort of order journey process about the language we use, so how we ask people about their gender identity, how we ask about their risk. And we do a lot of work with service users to ensure that the language that we use feels non-confrontational, is understandable, makes people want to share their information with us. We need to promote trust. We need to feel as though they're sitting in front of a person when they're actually maybe sitting at home in their time of need, when they're feeling anxious, concerned, and worried, and that we're taking them on that journey. We're supporting them to understand the space they're in, think about who they are, the type of sex they're having, and feel confident to share the information with us, that we can get them the right tool, the right service at the right time. So
yeah, it's so, I think, like, such a key thing you're drawing out there is the need for agency for all service users. And I think coming from the Brook perspective, which for a long time was really just about young people, and now is, you know, obviously much more about all age services. Like, my work with young people has always started with, like, how do I make sure I'm not being condescending? And how do I kind of invite people into conversations and get them excited about them? And actually, and I think everyone of all ages needs to feel that way, especially when it comes to health, especially when it comes to the more taboo aspects of health. And I think sexual health is a huge one there. So thank you very much for outlining that. Is there anything you want to add to that, Chris?
I don't think so. I think Sarah's done a great job. I think the one thing I would add actually is that there's a bit of a dichotomy as far as better targeting and profiling. So we know our users do not want to be profiled, and therefore how do you do that in a really discreet and helpful way as far as better targeting them with services which they we or they believe would be useful to them ostensibly. And again, we strongly believe in choice as being the best way in order for them, the agency, to choose which services they wish to draw down.
Can I can just throw this out quickly to any of you. I wonder, like, there's such an awareness of agency and choice and consent within the framework of all of this, which is amazing. Do you think that we in the sexual health services have that more than other health services because consent is so baked into this work? Or are you seeing this in other health services as well, and that's just not something I'm privy to?
I think it's typically front and center of most of our users' minds when they wish to access services.
Yeah. Okay. Anyone else want to hop on?
Yeah, I'd like to think we're the best in healthcare, and if we're not, we should be. Because it's a difficult area. People's very private lives are being displayed, and we have to build a trusting, engaging, enabling environment. And you only do that if you can give agency to individuals. And by offering an online service, people don't have to sit in a waiting room with their peers, or worried about seeing their peers. And there's lots of people, if they do read a newspaper anymore, would be reading it upside down, really just hiding behind it. No, people don't want to be in our clinics. So this is what's nice about digital, is we can start that conversation in the privacy of their own home, or while they're riding the bus on the way back from work. And then if they do need to come into clinic, hopefully we can get that transition right. And I think that is still a big piece about digital analog services. How do we get them to work really well together? There are ways of doing it, but I think we could improve on that.
Yeah, thank you for sharing. I want to stick with you, Anatole. I wonder if you're sick of talking about, like, hormonal contraception and misinformation, or if you're still, like, raring to go. Good. I think you're up for this. It's been, I guess, because I fall very much in the targeted kind of group of people who have had, what is it, maybe 7 years of a lot of targeted ads for fertility apps and for conversations online and offline, kind of questioning the contraceptive pills, I think for really good reasons in some ways. I have like lots of different versions of myself. If I put all the different hats on, I have a lot of empathy for this and a lot of direct personal experience of going like, oh, wow, I was actually, I think early on in my life, the information I had available to me about my contraception options was quite limiting. But at the same time, I feel really worried about that getting distorted on social media and there being a real wealth of misinformation that we have to kind of fight against. So when people come to you in clinics, are they armed with misinformation, and how do you respond to that? How do those conversations play out?
I'm not sure if how much is misinformation. I think I meet for want of a better term, ignorance or lack of information more than anything else. And also, I think lack of perspective. You know, a lot of people don't realize what we're comparing contraception against. So we're comparing it against a lifetime of pregnancy and breastfeeding, which was a lot of women, and and all the complications that used to happen back in the day with childbirth. And contraception has been designed based on what is the physiology in women, the hormonal cycles, as Eve Ensler has even written a book about. I'm a hormonal creature. We're dealing with individuals who are cyclical by nature and having menses. And we meet women at different stages in our lives. So, if you meet a young woman in school and she's missing days because of heavy menstrual bleeding, then we can obviously put her on the combined pill and address that, as well as her, if she's sexually active, not falling pregnant. So there are certain times in the lives of women where certain contraceptions are better. But if someone comes in and says, I've just been, bombarded with information that is anti-hormone, I want to do natural family planning with maybe some modern gizmos to make me feel a bit more reassured. The reality is that, we just need to hold up a mirror and say, well, sure, let's try and help you do that correctly. And let them know that there is a failure rate, there's a genuine failure rate, and that, there are other services around that, but they need to think about that. If a woman says, I'll never have an abortion, and she's then doing natural family planning and she couldn't fall pregnant because of, she needs to finish a degree or get a job or do whatever it is, then obviously it's worth, reflecting on the various methods that we have. Thankfully, we have the copper IUD. I'm seeing a lot more women coming in and opting for that at all sorts of younger ages, without me having to promote it. They've already made up their mind. So clearly, there is a conversation going on about the potential downsides of synthetic hormones that may be at the physiological levels that they're at, but they're synthetic hormones. And women are coming in and saying, I'd like a coil without me having to promote it, which is great. It's a fantastic form of contraception. It's hormone free. It lasts 5 or 10 years. It can be taken out at any time. The periods may get a little bit heavier, but otherwise it's just a great method. And so we do have options, which is great. But I think a good sexual health consultation will be trying to put it all into context, and if a woman is bleeding, 5 days every month, and it's quite heavy, that's 2 months of her year is bleeding. And if that's impacting on her, she may have anemia, she may have, have issues around period poverty and accessing, menstrual products. A contraception actually may help a great deal there. If she's got problems with the skin, a contraceptive pill may help there. So there's lots of things we can do, and a good consultation will try and tease that out. And there's lots of contraception sort of advice platforms out there. Brook's been involved in one. I know others have, and the website on SH24 is fantastic around contraception. It's just really get people to think about where they are in their life, what they'd be able to manage, and if they want hormone free, we've got good options as well.
Yeah, and we've got to give a shout out to condoms as well, even though people are shouting them out less and less these days, but we won't stop. Like the copper coil IUD is a brilliant form of contraception, but it's not the only one. And I think that's I felt a little bit like a sort of wild town crier talking to friends of mine about like condoms and natural cycles family planning, being like, could these two could they have a bit more of a conversation together? Yeah. And also, I guess a lot of the conversations online, by nature of our really short attention spans, ever increasing, it's kind of scratching the surface. What you're describing as a really good consultation is very like direct and person-centered, and gives a lot more time to think about all areas of someone's life, which is amazing.
Yeah, and condoms are great. You know, sex is so much more fun if you don't have to worry about bugs and babies, you know, and condoms deal with both of those. Yeah, if you're in a heterosexual relationship. So, you know, and there are so many different types as well, different sizes, latex free, you know, there's all sorts. So yeah, the humble condom doesn't get a big enough shout out. I agree with you.
Sarah, your hand is up. I wanted to kind of hear your perspective from the SH24 side with this as well. Are you seeing this in your digital services?
Condoms or?
Hopefully everyone's seeing condoms at the minute. No, I mean the kind of misinformation and
no, of course, yes. But just on the condom note, actually, again, there was a real push some years ago away from talking about inclusivity in condoms and perceptions around, and the sort of commissioning of just regular, quote unquote, external or condoms for a penis. And actually what we've seen over the years is that, you know, there's been a real pushback on that. And we're really, really pleased to say now that several of the commissioners in the regions in which we work have actually commissioned a far more inclusive barrier method service offer, and we're now able to facilitate access to dental dams again, internal condoms, all online. Yay. And the uptake has been really, really positive. So just a little bit of a plug there, because I think there was a bit of a concern, actually, would there be a proof of concept? Do people really want these things? And yes, they're flying out the door. So we're really, really pleased to see that people are opting in for those more inclusive, broader ranging methods of contraception, of barrier contraception. But yes, in terms of those perceptions, we don't tend to hear it because of the way that we engage with service users, because service users come to us for a service, for a product. But what we absolutely can attest to is that we see and hear it anecdotally by proxy of the partnerships that we're in, the spaces we occupy digitally, so in our social media spaces. But also we can't ignore that there has been a huge increase in what we would describe as, and I don't want to use this term flippantly, but an over-reliance on emergency contraception as a regular form of contraception. We are seeing huge amounts of repeat contraception, repeat EHC usage. We absolutely support service users. We offer them consultations with our nurses if they use EHC 4 times or more in a 6-month period. We try and channel shift people onto more regular forms of contraception, often unsuccessfully, which, you know, we can't make assumptions, because for all the reasons of talking about non-assumptive practices, but we can kind of make some assumptions as to why that might be or not. It's not always going to be because people perceive themselves or there's misinformation about hormones. It might just be actually about how people, the spaces that they occupy, the homes that they're in, safety, partnerships, relationships. It could be a whole plethora of reasons. But we are seeing, a real over-reliance on emergency contraception as a more regular form of contraception. And when I say that, I'm talking significant numbers of people who are using emergency contraceptions 12 plus times a year. So that's at least once a month. Some as high as 18 to 25 times a year. And of course, we're not going to say no to people. It's essential that they have that service. And again, when we look at the demographics of those users, when we look at who's accessing our online contraception and then who's accessing repeat EHC online, they are often different service users. So there's underrepresentation from certain groups in the regular forms of contraception and overrepresentation of certain groups in repeat EHC usage. So do with that information what you will. And without asking service users, and we do ask, but of course that relies on them engaging with us. We can't know for sure, but like I say, we can make some assumptions.
Chris?
I just wanted to reaffirm what Anatole mentioned previously about the value and impact of good content. So I'm a huge believer that high quality, easy to access content can really combat misinformation and go beyond that as well, to ensure people have got the right information when they need it. You also mentioned WhatsApp previously. We've got some really good experience of WhatsApp actually delivering services in sub-Saharan Africa. We delivered services to over 50,000 adolescent women over the space of 18 months. It was a fantastic service. So those types of new channels and leveraging social media for services and information, completely down with.
Yeah. And I think it's also about like catching them early and not being as afraid to lean in. I know I've had conversations with some Brook staff members in the past, just on personal levels. Like it took me, when TikTok was sort of growing hugely during lockdown, I felt a bit too scared to step in there because I didn't quite know how I would do it. And it just took me a while, and I was a bit nervous. And it was the first time there's been a new social media that made me feel a bit old, of going like, help, this isn't initially designed for me. And in hindsight, I really wish I'd just like got stuck in straight away. And I think there's an argument to be made to be a bit braver, whether that's kind of from my end on the like more personal side of things, but also for organizations and services to just give things a go, and see how they work. Because obviously from your experience, Chris, like they can have really positive impacts.
Absolutely, yeah. And just building on and using existing channels rather than building new ones.
Yeah,
that's what I'm doing.
Very true. Sam, I want to touch quickly on like misinformation and how we tackle that, but I'm also wary of time, and I want to give like 7 minutes for, we've got some really good questions. So yeah, what are your kind of key thoughts from a Brook perspective on misinformation?
Yeah, so I think we are conscious that it is there on social media. I think I could talk about this for a very long time. I think there's an important distinction to make between misinformation where it's kind of intentional in the sense that somebody's trying to kind of sell or market something, as opposed to people actually just talking about their own personal experiences and their own real life experiences with certain things, particularly around contraception. We know that content has a huge appeal to young people, and I think part of the reason why that sort of content has a huge appeal is that they don't get that information elsewhere. They're not receiving that information elsewhere, and so it makes sense for them to kind of be drawn to that, and they want to hear those real stories. They want to hear things that are relatable. I think the way that we approach some of this, tackling some of this on social media, and I have to give huge credit to our communications and policy manager, Eliza Bell, who does a very great job of kind of overseeing this. Because like you, Ruby, TikTok makes me feel very old. And so I think it's important kind of handing it over to people who are kind of more in tune with the language on the channels and really putting that great content out there. Now, that's not just about putting content out there that is accurate, but it's also about it being kind of relatable as well, and using the language of the platforms and the formats of the platforms to kind of work in that way. And that might include myth busting and information that kind of challenges those misconceptions. So if young people are in there, we know from our research that that we did last year, online sources of information came up as being the #1 place that young people go to for sexual health. About 66% said that that's where they turn. So as long as we've got the information on those platforms there for people to access, that's a positive thing. The other thing we've done is we've had a huge focus on promoting condoms on TikTok in particular, because I think we also have to accept that if people feel uncomfortable about using hormonal contraception, or they feel they've got concerns about that, rather than telling them they're wrong and shouting them down on that point, they're not going to kind of respond well to that. It's actually kind of much better to just kind of normalize the alternatives. And there's, condoms is a really, really good, effective alternative. And so that's what we've had, we had a TikTok last month that hit 1 million views just on, and it playfully engaging with some of the awkwardness that people feel around condoms, and really try to actively engage people in that side of things. And I think that's really key, is just making sure the information's on there on those platforms, but in a way that people are going to engage with and that feels it's not just that the information is accurate, but it's also relatable as well. I think that's really key.
Yeah, thank you so much for outlining. I've just been having a little look through the questions. Thank you so much. There are some really, really good points that have been brought up here. I want to prioritize a question about safeguarding concerns and online services from Kay Burton. So I wonder if Chris or Sarah, you'd like to kind of just mention that this question is thinking about online registrations for C-card schemes, but I think across the board, like, what do you put in place to make safeguarding concerns as streamlined as possible in digital services?
Yeah, we pioneered the delivery of safe, clinically led safeguarding across the country through digital services. It's complicated, and a huge amount of effort and resources have gone into it. Ostensibly, it requires some opportune questions and a lot of time of our clinical team in order to instigate wholesome conversations with those people accessing services, and then a very streamlined and competent referral and signposting process effectively.
Thank you. Anyone else want to add anything to that?
Well, a lot of things that we have online is, if young people are accessing it or people have had multiple tests, then, a referral, if there's a easy referral into clinic, then obviously we can pick up on that. And that's really about, another shout out to have, bring the digital and physical services closer together. But yeah, I think starting a conversation, a trustworthy conversation, be it online and then moving over to digital, is a good way of, then helpfully, having a relationship with the patient, so then they can disclose any safeguarding issues. There are a number of young people out there very sensible, and and we need to obviously acknowledge that. But for those who are victims of coercion or abuse, we just need to make sure that we can flag that. And it can be difficult. It can take a number of visits, even in clinic, to actually get any safeguarding flags coming up. But in the context of digital, there's a lot you can ask, as well as you can look at repeat behaviour to get flags.
Thank you, Anatole. I think we've just got time for one more, and one for any of the panel. Are there any questions that you really want to answer? If not, I've got one that I want to kind of put out, but I'm happy.
What I will just say is we'll make a log of these questions as well, and there will be a recording of this going up, and we can maybe put some responses to these questions out when we put the recording out as well. So just flag that.
Thank you. I implore the I can't think of the right word, the person who's asked a question about the key takeaways about pornography for young people. 5 minutes in, I'm so sorry, we need another hour if we're going to talk about that. But I hope that we get to do another kind of deep dive about that topic at some point soon, because that's something I'm really passionate about. But speaking as someone who did deliver an hour-long training on this subject 2 days ago and scratched the surface, I don't think we can quite get into it. There's final one about Fraser competency and online services. Is there kind of anything separate from the safeguarding conversation that you've put in place, Brook or SH24, to ensure we're kind of going through Fraser competency?
Yeah, the ideal method process to deliver that process is through in partnership with clinics, effectively, so hand in hand. That's not all online. It's there's a hand-holding process in clinic with a young person there, with trusted people.
Nice. Okay.
And I would just kind of flag on that as an example of that, and this ties in with one of the other questions I suppose around C-card side of things. Is a lot of online C-card offers may require someone to actually have gone in somewhere in person first in order to kind of register before they can use the online service, and therefore they've had that kind of face-to-face contact with a professional who's taken them through how to use condoms properly and make sure that they're kind of aware to use that. And I think that's a nice example of kind of what sort of the thing that Chris is talking about on a not necessarily a clinical level, but on that kind of community health kind of level as well, and how that can help with, you know, making sure that people are competent to be using the services and things.
Nice. Thank you, Sam. Right, to close up, I feel like this is going to be sort of game show style hosting, but I would like one short sentence from each of you. If we're looking to the future of sexual health services, what is one thing you are particularly excited about in terms of the way that your work is developing? We're ending on a high here. Does anyone want to start, or I can go full game show and put someone on the spot?
I'm happy to start.
And then I'll continue.
One sentence is difficult, but I would say integrated holistic services work which sees digital services working hand in hand with traditional clinics sensibly. So for too long, we've seen digital services being used as a bolt-on, as an offsetting tool. They're, as I think alluded to by both Sarah and Anatole previously, they're as a tool, they're much more valuable than that.
And they're not to be feared, because they're not, I really hope that they're not to replace in-person services. It is really a working in tandem.
Absolutely.
There's far more demand than capacity, and there's lots of issues that we don't get time to really dive deep on, such as mental health, drugs, weight, and other issues that are affecting our patients, our clients. So I think digital has the opportunity to really get into that conversation, find out where people are. And I'd like to see more development in that space personally.
Cool.
Yeah.
Sarah?
Anatole stole my words. Pesky Anatole. I was going to say pretty much that, redefining what is sexual health, the broadening of the reach of what we can do, but actually, and that exact approach Anatole's described, actually true holistic provision is about seeing a person as more than just their sexual health journey, and enabling their point of access with us to also tease out other sort of allied health services that may be required, and getting them in front of the right person at the right time. So that sort of connected journey.
Amazing. And Sam?
So mine is maybe kind of slightly to the side of the sexual health services, but what I'm quite excited about the possibilities of is the new RSHE guidance that comes into effect in September 2026 that has a renewed focus on engaging young people in issues around the content that they're seeing online. And I think we can help them, we can really use that as an opportunity to kind of rethink what media literacy looks like in a digital age, with in the age of AI and kind of influencers and things. And I think that's obviously a big job, but I think there's also like a lot of exciting potential there to be helping to equip, young people with the skills they need to kind of navigate the world online going forward and keep themselves safe and happy.
Amazing. That is a very poetic note to end on as well. So thank you for adding that. It's been such a joy to talk to all of you. I hope everyone at home and at work listening has kind of, you feel stimulated and like excited, and this has sparked a lot of curiosity. So thank you all very, very much for joining us, and a big thank you to our panelists as well. Just wishing you all a very happy Sexual Health Week. Thank you so much for joining, and a massive, massive thank you to Chris, Anatole, Sarah, and Sam. It's been a delight to chat with you all.